I present you Louis, a boy who was born with a cleft in his lip and palate. He has already received 3 years of speech intervention, yet it is still very difficult to understand him. Because of his speech disorders, Louis is often bullied, which negatively impacts his well-being. This case is not exceptional. About 7 out of 10 children with a cleft palate have speech disorders requiring speech intervention. Unfortunately, evidence for these speech therapy approaches was lacking. Also, evidence-based practice goes beyond the application of therapy approaches for which evidence exists. It involves an integration of the scientific evidence with the perspectives of the community SLPs and the perspectives of the patient and the family. Within my PhD, I investigated these 3 different cornerstones of evidence-based practice. Firstly, I investigated the practice patterns of community SLPs while treating a child with a cleft palate, and our results demonstrated that scientific findings do not always reach community SLPs. There exists an important research practice gap that might hurt the quality of the provided cleft services. Secondly, parents and patients consider speech therapy burdensome, mainly because of the applied intervention dosage. Mostly 1 or 2 therapy sessions of 30 minutes per week for months or even years. Perhaps the current service delivery models need to be reconsidered to decrease the experience burden. Thirdly, I conducted different randomized controlled trials both in Belgium and in Africa to investigate the effect of the content and dosage of cleft speech intervention. With regard to content, I developed a metaphonological approach specifically adapted to cleft speech characteristics, and this approach was more effective in improving speech compared to the traditional phonetic articulation approach. Secondly, my trial demonstrated that high-intensity speech intervention, which means that 10 one-hour speech therapy sessions were provided in 2 weeks, was more effective in improving speech and quality of life compared to low-intensity speech intervention, which means that 10 one-hour sessions were provided over 10 weeks. High-intensity speech intervention was a promising service delivery model that was able to improve speech in a shorter period of time. In conclusion, my PhD was an important first step towards evidence-based cleft speech services across the world. By providing evidence-based knowledge on patient-tailored cleft speech intervention, we, as speech-language pathologists, are able to treat patients like Louis more effectively.